Hello and welcome to my workshop, Behavioral Caregiver Training Model to Address Sleep Problems in Individuals with Autism Spectrum Disorder. My name is Kylan Turner. I thought I'd spend a little bit of time introducing myself so that you're aware of some of my background, how I got involved in research evaluating behavioral interventions to address sleep problems in this population. So I've worked with children with autism spectrum disorders since 2003. I earned my BCBA in 2010 and graduated with my PhD in special education in 2012 from the University of Pittsburgh. I was selected for a 2-year leadership and education in neurodevelopmental disabilities, LEND program fellowship, specializing in autism spectrum disorders. And through that fellowship, I developed and disseminated a training curriculum focused on applied behavior analytic intervention to medical and education community organizations throughout Pennsylvania. So I've got a very strong Pennsylvania connection. I was born and raised there and ended up doing most of my training there alongside one of my dear colleagues, Dr. Johanna Taylor. Some of you may know her from that community. We did that fellowship together. That gave me a great deal of insight into interdisciplinary clinical response problem areas, sort of the gaps that emerge for certain clinical populations when different interdisciplinary groups aren't able to effectively address certain target problems for certain clinical populations. And that's actually where I learned that sleep problems were a significant area of distress for both the clinical community, families, obviously the children or individuals with autism that were being served, as well as the providers were at a loss many times as to how to effectively address sleep problems. And so I'll get into, some of those discussions throughout this workshop. But I wanted to say currently I'm an associate professor of practice at Simmons University in the behavior analysis department there in Boston, Massachusetts. And I'm also the training director for a home-based behavioral services agency I helped to co-found here where I live in Providence, Rhode Island. So that's a little bit about me. Hopefully gives you some context as to how I got into behavioral interventions to address sleep problems and get us started here a little bit. I do want to say one other note, just a housekeeping note. I'm recording this here in my home office. There are children who also reside here. Many of the neighbor children have merged their bubble here with this household. So hopefully the recordings go smoothly. You may see me recording a bit of this actually at nighttime, so sort of appropriate for the topic. But I wanted to point out, hopefully there won't be too much discontinuity, but please bear with me as I attempt this endeavor. Okay, so the learning objectives for this particular workshop consist of attendees being able to list and describe the types of sleep problems children with ASD present and the effects of those sleep problems for the children and their caregivers. Also, we'll review the literature supporting behavioral interventions to address sleep problems, and we'll apply the various procedures to common sleep problems displayed in children with autism. And we'll finally examine the challenges and mitigating solutions to obtaining reliable data collection and fidelity of implementation when providing caregiver training to address sleep problems. Sleep, as we will discover throughout our next few hours together, is a tricky target problem to address for a number of reasons, both practical as well as just the nature of the sleep behavior itself. At times is difficult without highly expensive and obtrusive technology to measure. So we have to sort of work around that in our clinical practice. So here's a brief agenda. I'm going to very, very briefly, in a nutshell, provide some information on the caregiver training model and how I think that we should conceptualize it when we're talking about sleep problems and behavioral interventions to address sleep problems in particular. So I do want to talk a little bit about the model in general, very briefly, and then also just touch on some of the cultural, ethical, and professional conduct considerations that we should have at the forefront if we endeavor to address these problems through a caregiver training model in particular. And then we'll jump right in to addressing sleep problems. We're going to define sleep problems, talk extensively about the effects of sleep problems, in particular those effects exacerbating the symptoms of autism spectrum disorder, the challenging behaviors already being displayed. And then we'll spend some time talking about a variety of interventions. There are many to address sleep problems. And you'll see that it does take a multifaceted approach, a component package to effectively address sleep problems in most situations. And then we'll go through, obviously in the course of talking about that, the research associated with supporting those particular interventions, and finally a whole variety of additional considerations throughout that discussion. Okay, so the first thing I want to do is talk through the caregiver training model and some of those considerations specific to addressing sleep problems. So pretty sure, giving this talk asynchronously, that most of the audience members are likely familiar with this indirect service model, but just to be sure, to clarify specifically what I'm talking about a trainer with expertise in addressing behavioral, sleep problems, sleep disturbances, providing training to a caregiver. So that could be, the parents or anyone who addresses the child's needs at nighttime. And then we've got the child or the client or learner, depending on other aspects of the model that you'd be delivering service. Okay, why caregiver training? Again, I think that I could possibly be preaching to the choir, and so that's why I'm going to keep this very brief. But there is compelling evidence, right, to suggest that behavioral parent training is helpful, effective for both the individual clients as well as the direct clients, as well as their parents and other members of the family. So you can see through these various studies that there's evidence of decreased problem behavior. And of course, as problem behavior decreases, we often see parental stress, ratings of parental stress decrease as well. There's a particular study that I'll review toward the end of the workshop. It's a packaged program to address sleep disturbances in children with autism. And that was delivered through a parent training or caregiver training model. And we saw reductions in the sleep problem behavior. And then, of course, in addition to reducing problem behavior, we can see increases in acquisition and generalization across settings. Just got a couple of citations there to demonstrate that. Should anyone like to see more evidence to that end, I'd be happy to provide a reading list. So caregiver training requires us to really think about a few factors prior to jumping in. So there are three areas that I think intersect with this discussion. The first is cultural. On the next slide, I'll spell out cultural humility and cultural responsiveness, which are essentially terms that are replacing cultural competence, which has been a popular term frequently in the past, but the premise here is that we're now understanding we can't be fully competent in another person's culture. And so instead, we should think about how to become culturally humble or culturally responsive. So I'll talk about that again in a moment. But of course, we are duty bound to follow our ethical codes. So as a behavior analyst, I follow the BACB Professional and Ethical Compliance Code. Psychologists follow APA, educators, the CEC codes. all of these codes are very specific depending on the discipline, but I think the main themes that apply that I wanted to pull out in particular, talking about caregiver training and talking about addressing sleep problems in particular, are boundaries of competence. You know, it is difficult to deliver these interventions without having received some training in them, because there is a lot of indirect work that needs to happen, as most of us are not in the homes with our clients at nighttime. So competence is really important. Professional development should be sought. Informed consent. It is a vulnerable time for families. Nighttime, you know, evening, it's sort of a sacred family time. And I think it's very important that families understand what level of consent they're providing in seeking these services. So informed consent is important. And then seeking supervision. A lot of stuff can happen at nighttime. And so if these behaviors, you know, escalate, it can be challenging depending on the amount of supervision and the structure of the home, et cetera. And so just from an ethical perspective, it's important to make sure that we're all seeking supervision and really making sure that we're providing the best interventions and causing the least harm. Finally, professional conduct is really important. One of the most important things I think of when I think of caregiver training is that I want to educate the family. I want to inform them of all of the options. We are lucky as behavior analysts to have a wide array of behavioral technology available to us. And so although there might be some interventions that are just strongly indicated and sort of the best route to take, we do need these interventions to be acceptable to the family, especially considering that they might have other children, right, in the home, and an extinction burst could cause, you know, the whole family to be up for days, possibly weeks, right? So there are a lot of things to think about when it comes to sleep behavior and sort of the good of the group, if we're talking about a family. And so educating them on a variety of options and being open to that is really important. That goes hand in hand with establishing buy-in. We will be asking families to directly implement these behavioral interventions. And so they've got to have bought in. They've got to have that establishing operation to engage in the behaviors that we have taught them to engage in, to respond to problem behavior, etc., if we expect it to be effective. Finally, maintaining boundaries, I think, is something that, you know, can always be considered in any sort of caregiver training model. But again, in relation to nighttime events at a person's home, you know, the evening, again, it's sort of a sacred time in anyone's lives, even when it comes to families who are relatively used to, you know, professionals just spending a great number of hours in their home, for example. There's always a point where the family closes the door and expects to kind of have some time to themselves. So it's an area where we want to definitely make sure we're respecting boundaries and respecting, you know, the family's wishes and how they go about their routine. Okay, I promised we'd get back to these cultural considerations briefly. Lest you think that I'm getting to be a little too mentalistic in my discussion here, I wanted to point out that Skinner provided us with, I think, a pretty straightforward and conceptually sound definition of culture. It's a collection of behavioral practices. And so we can certainly talk about it. I think, you know, cultural humility and cultural responsiveness are certainly a little bit squishy and a little bit difficult to measure, but I think it's important as a guiding principle to consider these two factors. And when we're listening to families, when we're listening to them identify the target problems that they want to address. Sometimes as a therapist in the home, I'll go in and I will identify 5 or 6 things that I think are absolutely critical to address about the nighttime routine or what the family describes as happening in the middle of the night. But I need to also hear what the family is motivated to address, both from an efficacy perspective and a rapport building perspective, but also just a respect for, what the family would like to have happen in their family functioning and at nighttime. So cultural humility is a process by which we learn about other cultures and are sensitive to them. I think, again, the best way to do this is to be a really good listener, really identify what the family would like to accomplish and help them to nominate those target problems. And we are going to have insight, and as best practice guidelines would indicate, we are going to educate families on the consequences of not addressing certain problems. But I think at the end of the day, we get a lot farther when we just engage in these practices of humility and responsiveness, learning from and relating to individuals from other cultures. So just wanted to plant that seed and make sure that's kind of a big part of the context we're talking about here. Now I'd like to define sleep problems and their effects. These were part of the learning objectives for the workshop, so I wanted to make sure we really cover them clearly. So sleep problems. I think that this could also potentially be in the eye of the beholder, but many parents of children with autism report a high magnitude when it comes to these problems. This is not what you would see frequently in typically developing children, where they might wake up briefly in the middle of the night, need the covers placed back on them, and they're good to go again. They're good to be independent sleepers. Children with autism, when these sleep disturbances are reported, are more significant than just what I described. So they include a difficulty initiating and or maintaining sleep. Those are called dysomnias. And then they also include arousals during sleep, such as sleepwalking. This picture of this little guy, I think, is indicative of what a lot of families might report is going on. And we call those parasomnias, when there's an arousal during sleep. So we're talking about night wakings, we're talking about sleepwalking, we're talking about bedtime refusal. So evening tantrums that tend to persist for hours, such that the child is not going to sleep until a very late hour. Or I guess, they are waking up frequently and not going back to sleep for a long period of time, in excess of 10 minutes. And I've known some children that I've worked with who have insomnia, where they don't end up going to sleep for a 24-hour period or longer. And so you can imagine that's quite difficult. So the prevalence rates on sleep problems in this population, they vary a good amount. You can see here 44 to 83% of children with ASD report this as a standing problem. That range in the prevalence rate is due to a variety of differences in methodology to measure the prevalence rate, but all the same, even in if we consider it 44% being on the lower end, that's still significant. And this is between the ages of 3 and 15 years. So you can see that this isn't in that window of early infancy, right, when we would expect sleep training to need to occur, right? It's a newborn, it's a new person on the planet. They're adjusting and learning to go to sleep. We're talking about 3 years of age and older, a period of time when most typically developing children have addressed sleep training and have mastered some of those skills. It's most common when children are younger than 8 years of age in this population. Implications of sleep problems. I think we can all remember what it's like for all of us when we have experienced a lack of sleep. When it comes to children and child development, this has a tremendous impact on their neurological development, on their learning, on their memory consolidation, and particular with children with autism, daytime challenging behavior. So when an individual is not sleeping, it really does color the day. It colors how they respond to, I don't know, changes in routine, or, you know, those common antecedent stimuli to problem behaviors. Everything is exacerbated when there is a lack of sleep. And I think we can all relate to that personally, and we can put ourselves in the shoes of an individual with autism, and recognize that without that sleep in their system, it's certainly a setting event that has a profound effect on how they respond. I've been particularly interested, and I only provided one citation here, and it's I think this is a basic research study about the interaction or the bidirectionality of the presence of anxiety and depressive symptoms, or potentially post-traumatic stress disorder symptomology. We all know that when those diagnoses are present, or those clinical issues are present, that there's an impact on sleep. However, what's been interesting is more and more studies have attempted to address the sleep problem, and have sort of separately using behavioral interventions, and it has had an effect on the clinical diagnoses of anxiety, depression, and PTSD. So I thought that that's something worth sharing, is that when we treat sleep problems in individuals who have these other clinical symptoms, then those clinical symptoms decrease in severity. And so it's possible that by addressing sleep problems in children with autism, we can assist in some of those areas as well for them. So just wanted to put that out there. It's certainly an area of continued research to sort of connect many of those dots, but I think it's helpful to think about that perspective. Okay, the effect of sleep disturbance on families. I think that anyone who's been around a child or cared for a child knows that it's important to have some good sleep. Your frustration level will certainly be less disrupted when you've had a bit of sleep. And so it's not surprising, right, that when a child is up with sleep disturbances, parents have disturbed sleep, right? Rarely is it the case that a child is just sort of quietly playing in their room. It certainly happens, and we'll talk about that when we talk about the assessment of sleep problems and reliably detecting sleep disturbance in children. However, typically when a child is awake, they're waking up their parents, they're waking up others in the household. So they're reporting their own sleep disturbance. They're reporting elevated stress. Again, it's stressful to not have that regular sleep. They're also reporting their anxiety and depression. And so what we do know about parents of children with autism is that stress, anxiety, and depression are already elevated in that group of people. And so when sleep disturbance is piled onto that, just like we talked about with the children, all of those symptoms are going to be exacerbated as well. So it's a large issue, and it's possible that if we address those sleep problems, we can see some improvement on that front. Okay, now I'd like to transition into talking about the behavioral assessment of sleep problems. So there are a couple of things that are a little bit tricky about sleep problems, as I had previously mentioned. The first thing is the fact that we as practitioners are frequently unable to enter the home, right, at nighttime, be there for when these problem behaviors are occurring. And so therefore, we need to rely on caregiver report. So whomever is in the home with the child at night will need to be responsible for reporting to us what is taking place. Given that as a behavior analyst, I commit to providing function-based interventions, there's a little bit of a difficulty there if I don't have the proper assessment data in order to determine the function and then identify the function-based intervention. So I think it's best to just obtain as much information as is possible. Frequently, we will see, and actually as I'll talk through each intervention and procedure, we'll see the different types of sleep problems that typically occur, and you will see that most of the time these are likely multiply controlled. But across all sleep problems, I would say attention is a primary function or the primary function. And that can be displayed or investigated when we see that a child is calling out for a parent to enter the room for one reason or another. And then also we'll talk about how access to tangibles is also a frequent function for night wakings if the child hasn't had a snack or water or things like that. And then also escape, right, when we see bedtime refusal. But most of the time, attention is a major function. So it's just something to keep in mind in general when it comes to sleep problems. So the tools that we can use to assess sleep are frequently what we call sleep diaries. Sleep diaries collect a variety of information. You can kind of think of them as ABC data collection sheets that would record the antecedent behavior and consequence, perhaps other setting events. But what makes it a sleep diary, or what makes it a little bit unique, is that we also have data recorded for each night on when the child is placed into bed, when they are actually falling asleep, and then the time of and duration of any night wakings. So if they wake up at 1:30 in the morning and stay awake for a half hour, you would have 1:30 a.m. to 2 a.m. recorded there. And then also the ultimate wake time. So sometimes we see 5:30 in the morning is the wake time for a particular child, and that would be recorded in the sleep diary. So it includes an area for recording particular problem behavior, antecedent behaviors, consequences. If the child is told to go back to bed and they just keep sneaking out, things like that are recorded in the ABC section. So sleep diaries do depend on a parent's report. And what's tricky about sleep behavior is that even an incredibly well-trained, incredibly reliable reporter may fall asleep, right? They might miss some of the problem behaviors because they're trying to get back to sleep themselves. And so what does sometimes happen in the treatment of sleep problems is that if we aren't able to address the child's underlying, perhaps biological factors for their sleep disturbance, we see kids that end up being quietly awake. And so an adult caregiver might not record some of those instances when the child is just sort of awake and sitting up in bed, but not being disruptive enough to rise to the level of a parent waking up and then getting their sleep diary data recording form to log that instance. So sleep diaries are really helpful, especially identifying some of the really overt events that we're trying to record. However, for some of the lower level, less detectable behaviors or events, sometimes sleep diaries can miss some things. So we also have other tools that are objective and can be much more consistent and don't fall asleep, right? Infrared nighttime video, or what we call sometimes nanny cameras, can be really effective in capturing what that child is up to at night. And so, but one of the weaknesses with those, that particular type of tool, video recording, is that it is a bit obtrusive, and sometimes families feel that that infringes on their privacy a bit. It can also be expensive. There might be some practical limitations in terms of like data storage. You know, do you have access to the cloud to be able to put that video up there, etc. So there are some considerations with that, but I would say from a strictly data collection perspective, it's reliable. One question is, you know, is it totally measuring sleep? If the child is laying down and not moving around a lot, but their eyes are open and they're clearly awake, you know, you want to make sure that you can still capture that. And so another tool that I want to talk about that can possibly fill that void is the actigraph, or actigraphy. Is the measurement of the activity of the individual. And you can see I have a little picture here. It looks like a watch. It's worn on the wrist. And if you collect data over 14 days or 14 nights, you are able to, there's actually an algorithm for sleep. And so it will collect the activity data, and then it will run it through this algorithm to determine what level of activity has occurred and what fits the pattern of sleep behavior, so that you're able to end up with some pretty hard output, objective output, regarding the total sleep time, so which is a helpful statistic to have, because you're able to say, okay, well, this child might be waking up a lot at night. However, they are, you know, sleeping 11 hours every night. And so perhaps that's developmentally appropriate, or for that child, but we want to reduce the night wakings, for example. Or perhaps there are many more night wakings than anyone has detected, right? And this child is actually awake much more than even the caregivers knew about. So you can collect a lot of great information from actigraphy. And in fact, you know, several years ago, when I was doing my dissertation study on behavioral interventions to address sleep problems, we had these clunky, cold metal actigraphs that would break frequently. Now you can use Fitbits. They actually have the internal mechanism of those original actigraphs are in those exercise watches, fitness tracker watches. And so they're a little bit more palatable, but the difficulty with actigraphy with little kids is that it's still clunky, and especially kids with autism find it difficult to keep them on and sleep. So on some occasions we saw children's sleep problems actually increase, because they were wearing the actigraph, which was intended to measure their sleep behavior, and so that was not helpful. And so the alternative is you can actually put it on the child's ankle, and if their pajamas sort of allow it, it can be less detectable. But that's sort of the drawback of actigraphy is that there's some practical limitations. So I just wanted to give folks a lay of the land of how you know, various research studies have gone about assessing sleep problems, and how we as practitioners might want to consider various approaches to measuring sleep behavior reliably and accurately, but also keep in mind no tool is perfect, and perhaps a battery of tools might be the best way to go. Here we see this a great study by Jin, Hanley, and Bao Liu. You can see that they use sleep diaries, infrared nighttime video, and through that they were able to measure sleep onset, so the time that the child actually fell asleep, sleep interfering behaviors. I would call these night wakings, or I guess actually they have night wakings. So sleep interfering behaviors might be sort of bedtime refusal, total sleep, parental presence. You know, sometimes we as parents are walking around in the middle of the night and, you know, addressing the sleep problems and aren't recording them. And so that can be a helpful sort of backup with the nighttime video along with the sleep diaries. Also, medication administration was recorded through this. And so I sort of spelled that out on this slide, so you can see that here. So I just wanted to again highlight the fact that many of us think of sleep problems and their assessment. You need a sleep study, you need to spend a night in the hospital, you know, being hooked up. And I've actually noticed in doing this work that many parents of children with autism don't always report to their clinicians, their in-home, you know, behavior analysts or even teachers or other folks in the environment that there are sleep problems, or they don't push the issue because many parents might be under the impression that only medication is an option. And the medications that we use to address sleep problems are quite strong, and they lack efficacy and safety data for young kids. And so some of the parents I've talked to have said, yeah, he has sleep problems. We're just hoping that it's going to grow out of them. Parents don't need to do that. They can actually seek these behavioral interventions and plans specific that can be delivered in home. And so it isn't necessary, absolutely in every case, for a child to go through a hospital-based clinic and have a formal sleep study just to verify what they're pretty sure they already know. There are a lot of less obtrusive assessment procedures as well as less obtrusive interventions. And so we can, then medication. And so that's what I want to talk about now, are actually these behavioral interventions to address sleep problems. So you'll see here, I broke them down into antecedent-based and consequence-based interventions. I'm going to go through each of these, and for a few of them I have a few videos. I actually did a review on behavioral interventions to address sleep problems in this population back in 2012. You can see Vrend and colleagues in 2011 did a similar analysis of some of these. And so I am going to primarily talk about the procedures, describe the procedures that are outlined in the literature based off of these reviews. Should anyone like to see a more comprehensive list of readings on these specific procedures, I'd be happy to provide them. I have a comprehensive reference list at the end of this slide deck, and would be happy to circulate readings and resource lists also. But for the purposes of talking about these different interventions, I worked off of this review, these reviews of published studies with this population. Okay, so going to start with positive bedtime routines. So actually one other note before I advance here. I wanted to talk just, I think for many behavior analysts, this is sort of a no-brainer, but I just want to emphasize, you know, sleep is funny because it isn't the sort of problem behavior where, you know, you can provide immediate differential reinforcement for its occurrence, right? You can't watch a child fall asleep and then wake them up and say, good job, here's a cookie, right? Or, you know, a token board or something like that. You can't do that. It's going to defeat the purpose of, you know, trying to increase or promote that behavior. And so much of what we need to do to address sleep problems needs to occur on the antecedent side. Okay, we need to really focus on those motivating operations and really make sure those EOs are at strength for sleep to occur. And there are a lot of environmental manipulations that we can do to occasion the behavior of sleep. Now that said, once we do all of that, if there are lingering issues, then we do engage in the consequence-based interventions. What I've found is that when you go through this gamut of antecedent-based interventions, you sort of clean everything up, you're able to more reliably predict and control elements of the sleep problems that are being displayed, and then the consequence-based interventions can be used in a much more targeted manner on specific behaviors that you're able to observe between the client and the child in this case. And so I think that's just something I wanted to really emphasize. It's not sort of an either or scenario, and at least from my perspective in addressing sleep problems, go through the antecedent-based interventions, get those as consistently in practice as possible before seeing how much the consequence-based interventions need to be implemented also. Now there might be some exceptions to that as we talk about different scenarios, but the first one I think is just universally necessary is the positive bedtime routine. This should be implemented, frankly, whenever there's any sleep problem, from my perspective. The literature has shown that just using positive bedtime routines when there's bedtime refusal or difficulty initiating sleep it's most effective. But I would say that I use this routinely, no matter what the issue is, again, to sort of clean up the whole sleep situation in the family's home and in the child's life, and then you can really suss out what else needs to be done. Okay. So to implement this intervention, the first step is to collect a comprehensive schedule or sequence of events in a typical day. And so for any of you who are remotely interested in learning about sleep, one of the common sort of terms that is out there is sleep hygiene, things that we should all be doing throughout our day to ensure that we promote sleep. And so what I do is I explain that to the family. You know, we're going to just take a really close look at your day. We want to know the child's wake-up time, if they're still taking naps, either as an intentional part of the day or sort of accidentally because, you know, they're on their way to a therapy appointment or they're picking up older brother at soccer practice and, you know, there's traffic and the child falls asleep. I want to know how frequently that happens, and then also the duration of those naps. As we can all probably imagine, when one is taking naps during the day, it's decreasing the probability that they'll necessarily sleep through the night or go to bed at a particular time. So we want to know about that. We want to know what the official bedtime is. I say it that way because a lot of families will say, well, bedtime is at 8 o'clock, but my child doesn't fall asleep until 9:30. So it's important to understand what time in the household the process is getting started for bedtime. And then I want to also know what time they're actually falling asleep. You know, what is the duration between those two periods, and we'll get into that in a little bit as well. But we want to know this information. We also want to know what the typical wake times are. So what times do they typically wake up in the middle of the night if they have night wakings, and also how long are those? So this could be gathered from the sleep diary, but I'm also interested in kind of all the activities throughout the day. How much exercise is the child getting? How much outside daylight time are they getting? Without getting into the physiology of it too much, as humans, human organisms, we do respond to those environmental cues. And so, if the child is, cooped up inside in front of a screen for a really long time, that's going to impact their body's clock, their internal clock. And so I want to know kind of what exposure they're getting to all of those different stimuli and in what order, etc. So the more comprehensive a schedule you can get from the family, the better. Then go through that schedule, and I'll show you an example in a little bit. Go through that schedule and ask families, what are the non-negotiable aspects of their daily routine? You know, some things are non-negotiable, you know, school start time, you know, the session time for certain therapists, you know, as I mentioned, picking up another child from an activity, etc. And then what are the problem areas of the day that relate to sleep? So are there naps happening? You know, are there other parts of the day that are riling the child up when they should be calming down for bedtime? And so the third step in the positive bedtime routines intervention is to then take a close look at all sorts of guidelines on sleep hygiene. I have a few of these written here that might be specific for children with autism in particular. But the idea is to educate the family on sleep hygiene in general. What will promote sleep? What are kind of the big no-nos if you're really trying to, you know, ensure that sleep will occur? And so some of these I've written here: avoid certain settings or people at nap time or bedtime. You know, if Uncle Johnny likes to stop by 20 minutes before the child's supposed to go to bed, and Uncle Johnny's kind of like the human jungle gym for the child and, you know, gets them really excited and wound up, and then all of a sudden they're supposed to go lay down and fall asleep, we might want to ask Uncle Johnny to visit earlier in the day. And so avoiding some of those people, or settings, right, that might be difficult for the child to sort of power down when it comes to bedtime. We also want to control the environment, so consider the temperature, consider the noise level. You know, if they have an air conditioning unit in the window, is that particularly noisy? You know, do they live on a busy street? Things like that. Do we want to get some sort of a white noise machine to sort of cancel some of that out? So different ways to control the environment. When I was doing a study on behavioral interventions to address sleep problems, I would go on home visits to specifically see what the child's bedroom was like and their sleep space was like. And I would frequently ask the family, you know, what does it look like with the lights off? Do you close the blinds? Things like that. Sometimes you might want to ask about whether they're interested in, you know, putting blackout curtains up if light is a particularly problematic stimulus for the child. But on one occasion, I actually was looking at the child's room, and, you know, it looked actually like they had controlled the environment quite well. But I noticed that they had a nightlight, and it was the child. It had the child's favorite character on it, cartoon character. I forget which one. And so the child liked it, and they had put it on the outlet closest to the head of the bed. And so without even realizing it, you know, the child had a light sort of shining right in their face. And that was something we were able to switch to a different outlet, and it helped a little bit. And so I think sometimes we as practitioners are really able to bring in fresh perspective. I know in my own home, I'm sure that if someone else could come in and give me the fresh perspective, shake me out of my routine. Sometimes we're a little too close to our own routines to see what could be modified about a space, what could be modified about our own schedule and plan. And so that's kind of the idea with positive bedtime routines, is to evaluate those elements and try to gear the family toward a sort of more sleep hygiene conducive schedule. So changing setting events, of course, so eliminating that nap, or perhaps waking the child up earlier if they tend to sleep in. If they tend to sleep in, then they probably are going to bed later. And so, you know, we could adjust some of those setting events in that manner. Change the order of events. Obviously, the Premack principle is great in that regard, but we can also consider changing the order of events to promote better sleep. So many families might have the child bathe in the evening. For a child with autism, or actually any child, perhaps a bath or a shower is very activating, right? It has it promotes more activity. It wakes the child up. And that might be an activity you want to move to earlier in the day instead of one of the last things that happens in their night. You can change how you ask or respond. This is sort of a basic parent training approach of, how can we present task demands and how can we respond to problem behavior differently. And then also using visual or auditory cues, some sort of a clear, concrete schedule of this routine that's very salient for the child will reduce some of the bedtime refusal and promote compliance. Okay, so I provided a really basic, off the top of my head, schedule that a family might provide you. I started with 2 p.m., but in practice, you would want to start much earlier in the day with the wake-up time. I just thought for the purposes of this slide, I would keep it a little abbreviated. So here we are at 2 p.m. The family, parents, caregivers pick up the child from school and drive them to speech therapy. Oof, he usually falls asleep in the car for 30 minutes. That could be a problem area for us. So I just stated that that's a problem area. And then he has speech therapy for a half hour. He eventually comes home and he has some leisure time, just sort of a no demand situation, free access to the TV and iPad and other activities. So this is potential reinforcing. These are potential reinforcers. We also have dinner time here. He wanders around while eating and enjoys a cup of soda. So again, I've actually encountered this quite a bit. And this is, a decision that the family made to allow soda. I talked to the family about the fact that caffeine is certainly a problem area if we're trying to promote sleep. And if the family is still open and interested in the child having access to soda, that they needed to provide it much earlier in the day. But ultimately, in many of the cases, we just eliminated it. And so just something to think about, asking families, what are they consuming? Sometimes it's so normal for a family that they wouldn't think to indicate it. And so I think I put that there as just another way to make sure that you're kind of identifying all of the possible contributing factors to the sleep problem. Okay, and then we have bath time, which is usually a struggle, and afterwards he's very hyper. And so I put here, this is a problem area, the bath might be too activating. All right, and then 7:15, there's a lot more TV watching or the iPad in the bedroom, and that could be a potential reinforcer. But one other thing we know about sleep hygiene is that the blue light that our screens emit actually have a pretty powerful effect on the brain, and it's not conducive to sleep. And so usually we want to see that those screens turned off and an hour before we expect someone to be falling asleep. So something important to keep in mind. This is already 7:15, so it's pretty late to be doing that. And then it looks like the TV watching kind of flows directly into being asleep, and they sleep on the floor next to the bed. So something else to think about. We want to eventually probably get them into their bed, but one thing at a time. We're focused on the schedule here. So then we see that there are 2 occasions of night waking, and that a snack is what gets them back to sleep. So that's important for us to know, right? That could be something that we could really think about. How do we get more food in the belly before going to sleep? So I got very fancy here with my animations. This is a typical sort of document I might provide to the family. So we have this previous schedule that I just went through, and here we want to create a new bedtime schedule or a new sleep routine for the child. So I dated this February 7th. And so I do want to just back up briefly, actually. So 10:30 is when he's actually falling asleep, okay? So it's important to keep that in mind. So you'll see in a minute why I chose 8:45. I sort of just identified what time we want the child to end up in bed. And then I worked the various activities back from there. So here, instead of having free access to these various screens, we're going to turn the screens off, and we're going to actually have them engage in some exercise just to get them out there. Perhaps I noticed earlier in the day there wasn't much exercise. If it's possible for this child to get outside as the sun is going down, although 8:45 is a little bit late, it would be good for him to be outside doing some exercise in the late evening, but even indoor exercise would be helpful. And then at 9:15, books and quiet activities. 9:45, snack. Now that might seem a little strange. Gosh, that's late for a snack, but he's waking up at 2 a.m. and 4 a.m. hungry. And so whatever is happening at dinner is not, sticking with him. And here Sam needs a bit more to eat. And so if we fill his belly, we might be able to prevent some of those night wakings. So then we'll brush teeth, use the bathroom, and then I actually was thinking of a particular family when I put this, but we want to usually end with a very salient cue, a very salient stimulus for the child to associate with, the lights are going to go out and it's going to be bedtime. There was this one family I worked with. The mom loved to sing songs to her children, and I said, can you pick one song that you can just sing, and that'll be your sort of good night moment for you and your child. And that was a very positive experience for her, positive experience for the child, got the child nice and calm. So you can think about anything. It could be a hug, it could be a snuggle or something, but in this case, mom sings a song, and Sam will be in bed by 10 p.m. If you look at his current schedule, you'll see that he's typically only falling asleep at 10:30. So when it comes to positive bedtime routines, we're trying to clean up the day. We're not going to mess with the actual bedtime quite yet. We're going to just ensure that he's only getting in bed within 20 minutes of falling asleep. We don't want the actual bed or the sleep space to be associated with goofing around, with jumping up and down, with watching a screen or any of that. We want the sleep space to evoke sleep. And so we want him to be in bed as close to falling asleep as is possible. So the positive bedtime routine, we're trying to promote sleep. We've infused additional activities that are going to hopefully do that. And we're going to use other interventions to slowly back up that bedtime, assuming that the family would like to do that and that it makes sense for the child's overall schedule for him to go to bed sooner. I personally like when my kid's in bed early, but some families, they have a different schedule, or the child isn't in school yet, and it makes sense for the family's work schedule for the child to stay up a bit later. So every family's different. We'll have to ask, is 10 o'clock too late? But hopefully positive bedtime routine, this particular antecedent intervention will at least clean up the evening routine so that there aren't problem behaviors associated with that. So in addition to trying to implement these last 5 steps, starting at 8:45, we're going to try to limit that nap in the car on the way to speech. That's tricky, but we'll see if the family can try to do that. We'll try to move the bath to the morning, again, to reduce that probability of activation, or perhaps the bath could be as soon as he gets home from school or something like that, but far away enough from our bedtime routine so it's not an issue. We want to stop screen time starting 1 hour before expecting sleep, so no more screen time after I would say probably 9-10 p.m. and then eliminate the soda. Okay, so the next intervention I want to get into is the treatment of sleep association problems we as behavior analysts might think of this as stimulus control, restricted stimulus control issues. So a few things to talk about regarding stimulus control and sleep is that we all have stimuli that evoke sleep for us. If we think about what we have in our actual sleep space, if you all can picture your bed that you sleep in every night, you probably have certain pillows, a certain weight of a blanket. It's summertime right now, so perhaps you have sort of your summertime bed set with a certain type of blanket, and you sleep in a particular position. All of these are aspects of stimulus control that evoke sleep for you. Oddly enough, until I started studying sleep behavior, I didn't know this, but it's fairly typical for people to wake up in the night multiple times. Now, if you are an expert sleeper, which means you're a good sleeper, you have mastered the ways in which you need to rearrange the stimuli in your sleep space to evoke sleep again. And so let's say, you typically wake up for a moment at, 2 in the morning, and you adjust the covers, you adjust your pillow, and or you turn to your other side, and you are able to evoke sleep again. Those small adjustments are really based off of the stimulus control that you had acquired. And I say you're an expert sleeper because we all need to start thinking about sleep as a behavior, right, that can be learned. And if we think about typically developing kids, most of the time that learning happens in infancy. Individuals with autism, they might acquire it for a while, but it might also require odd stimuli or a plethora of stimuli or very specific stimulus arrangements to occasion sleep. So it might be fine if you have a caregiver who's very attuned to those various stimuli arrangements. Okay, you need your stuffed bear to be here, and you need to be having a sippy cup, for example, here in your mouth, and you need to be twirling your hair or a baby doll's hair, or you need to be rubbing, a part of a special blanket on your cheek. We can picture all these things being necessary for a little kid. The child with autism might have that restricted stimulus control that is present across the rest of their day, also appearing at nighttime. So when it's 2 a.m. for them, instead of being expert sleepers who are capable of rearranging the stimuli in their environment to re-occasion sleep, they aren't doing that. And so they wake up in the middle of the night, and a caregiver has to come in and rearrange all those elements again to occasion sleep. So the sleep literature calls these sleep association problems. As a behavior analyst, I think of them as faulty or restricted stimulus control. So the good thing about that conceptualization, I had some pictures here. This little guy can't fall asleep without his brother. Kind of sweet, but also maybe eventually the brother might want to be in a different space. Some kids need, the visual of certain toys being present. And at first, maybe as a parent, you're like, okay, no problem. I'll have these toys present. What happens when you're in a hotel? What happens when you go to visit grandma and grandpa's house, etc. And so the more kind of complicated the arrangement of stimuli are or become, the more a family has to kind of construct that space. Here we've got a little girl who's got a pacifier, right? So that's part of the experience we need to think about for her to occasion her sleep, and she's got to be between two parents. So again, what if one of the parents needs to work the night shift or something, or for whatever reason isn't able to be present? That could cause an issue. Okay, so in order to address these problems, again, I recommend conceptualizing them as stimulus control issues, okay, faulty stimulus control issues. The first thing we want to do is analyze all of the stimuli present when falling asleep. Sometimes I've had families take a literal picture of what the child looks like shortly after they've fallen asleep. So we can see, right, where's their hand? You know, what are the stimuli that need to be there? Are they, you know, holding a particular item? Are they needing, like, do they have a pacifier type object? Do they have, you know, a particular pillow that needs to be there? And then I have the family tell me, you know, if this blanket's not there, sleep's not happening. I need to know what are the required stimuli. Once we have an idea of what currently evokes sleep, we want to talk to the family about the terminal goal. Now, some families might say it's perfectly fine to keep that blanket around, but man, we want to get rid of that sippy cup. Or, you know, it's some families still co-sleep. And again, that's something that's up to the family. It's another cultural consideration. Our job is to educate families on the fact that, you know, there might be a point in time when you don't want that to happen anymore. You want to get your night back. And perhaps while we're addressing these other stimulus control related issues, we want to get you out of that bed. Some families might lay down with their child until their child falls asleep, but then when the child wakes up and the parent isn't there, they've got to go back in there. So I would ask the family to identify the terminal goal. What are the stimuli you're comfortable with the child keeping? And what are the stimuli you really want to start to fade out? And so then you create a systematic stimulus fading or shaping plan from the current stimuli to the terminal stimuli. So perhaps you might start with the parent laying next to the child with a teddy bear present. The family says, the teddy bear's fine. We're okay with that. Even if it falls out of bed, we're happy to just go in and plop it back on there. But I do not want to spend an hour every night laying next to my kid waiting for him to fall asleep. So maybe we fade in a body pillow, okay? Now that wouldn't happen overnight, but you could identify those you identify the terminal goal and small successive approximations to that. You systematically fade out the parent such that the parent is laying with the child. The next night, you might put the body pillow in, but have the parent hold the child's hand. The child might cry and protest, but after you're able to have a few nights of the child responding favorably to that, lower rates of crying and tantruming, you then fade to a couple feet away, etc., and just fade yourself out of the room. So I created a video. Was able to cajole my 6-year-old into doing this. He was very keen to be on video, especially to pretend to throw a tantrum. However, he did not want his bedroom to be filmed for some reason, little control issue there. So we used another office in our home. So please use your imagination that it's a children's bedroom. But what we did for this video is we pretended that he needed 2 particular stimuli to fall asleep. One is a huge bath towel, okay? So we pretended was supposed to snuggle this bath towel and simultaneously have a full cup of water. And so these would be considered the current stimuli. Over the course of the video, since I'm not a professional video producer, I want to explain this a little bit. We faded the towel, the big towel, first to a terrible towel, go Steelers, just because it was smaller, just to reduce some of the bulk. And then we faded it eventually to just a washcloth. Again, it's somewhat arbitrary what's decided to be the more acceptable stimulus, but in this case, you can see how that fading sequence might occur. And then with the full bottle of water, faded it first to an empty bottle, so no water in it, so lighter. Once the child got used to it being lighter and also not being able to drink the water at night, we faded it to the bottle lid. And I'll point out, I actually didn't know that this straw could come off. My son told me after we filmed. But so you could imagine when you watch the video that the straw is off and he's just got this lid part to suck on. So it's a little bit smaller, right, than the whole shebang. And then no bottle at all was the last phase of the process of systematically fading these stimuli. So hope you enjoy this video, and I will see you after to talk about the next intervention. Oh, buddy, sorry, I forgot your towel. Here's your towel. Here's that. Okay, good job. All right, good night. Sleep tight. Okay, that's right. Here we go. Here's that, and then here's this, bud. Yeah, there you go. All right, good night. All right, here you go. Here, there's your lovey. All right, good night. Okay, I'd like to continue by talking about bedtime fading as another antecedent-based intervention, excuse me, to decrease some sleep problems. So bedtime fading should be used particularly when there's a sleep latency issue, we call it. Essentially when there's a long delay between being in bed and falling asleep. In the sleep literature, it's called delayed sleep onset. Sometimes in actigraphic recordings, it'll say sleep latency. But ideally, the sleep experts say that when in bed, we should all be falling asleep within 20 minutes. Once we've got the lights out, once we've got our stimuli arranged to occasion sleep, it shouldn't take longer than about 20 minutes for that to take place. So when it's longer than that, we say that there's delayed sleep onset. And again, from the perspective of the contingency, right, the analysis of the stimuli occasioning the behavior, that makes sense, right? If the sleep space is able to occasion sleep reliably within that 20-minute period, that's how long it takes for our bodies to fully power down. Many of those sleep hygiene professionals, experts say that, in fact, if you're not falling asleep within 20 minutes, you should get out of bed, because you don't want to be in a space, again, creating new associations in your sleep area while not sleeping. And so, there are a few, just some different examples of things I've heard about that kids might be up to when they are experiencing this delayed sleep onset. In this case, the little guy is watching the iPad in bed. Maybe during the day, that might not seem like a terrible idea. It's a comfortable space for the child to be. But if it's bedtime and bedtime is now being associated, or that sleep area, is being associated with screen time, then that might present some difficulties. Again, bearing in mind that individuals with autism in particular are going to have some stimulus control issues in particular. You want that sleep space to be a very distraction-free environment, and again, just have it occasion sleep. I just found this picture of the child covered in Sharpie marker, and thought of some of the clients I've worked with who've just sort of been up to no good in that period of time. The parents think that they are actually falling asleep, and they're doing things like that quietly in bed. And so we want to decrease that latency period and have it be a relatively rapid transition for the individual to fall asleep. So how do we close that gap when there is this latency issue? The first is to set bedtime close to when the child is reported to naturally fall asleep. You know, there's a lot of judgment out there when parents express that, you know, they let their child stay up late, right? And so I think because of that, some parents are conditioned to, you know, want to, you know, report an earlier bedtime, etc. For me, the most important question is what time is the child actually in bed and being left alone with the expectation of falling asleep? That's the bedtime I'm most curious about. And what kind of gap is there? And then also what time is it that they're actually falling asleep? We need to use that as our first benchmark. So if it is 10:30 or 11 or midnight, okay, that's our starting point, right? That's when they're naturally falling asleep. So we want to then just push the official bedtime to be 20 minutes before that. So if it is midnight that they're actually falling asleep, the child isn't going to be in their bed until 11:40. Now that sounds a little bananas. I wouldn't necessarily want to hear that myself, but it's, you know, this intervention again is about being able to predict and control when that actual sleep onset occurs. And we want it to happen in conjunction with that sleep area, that sleep space. And so those two things need to happen together. So if you're pushing back the official bedtime now, instead of, you know, the hopeful 8 p.m. bedtime now to a much more realistic 11:40 p.m., you will need to program more activities in that time period, right? So we want to, again, tire the child out, strengthen that establishing operation for sleep. Maybe we want to make sure that our positive bedtime routine is all set up. Bedtime fading and that positive bedtime routine go hand in hand, as does treatment of those sleep association or stimulus control issues. So you can see that each of these interventions plays a different role a little bit. For me, I like to make sure that that positive bedtime routine is up and going before we start the bedtime fading. Because once we start the bedtime fading, it's, well, you'll see, we're focusing on that latency. So once you're able to reliably have that child fall asleep upon being put in bed at 11:40, they're falling asleep at midnight, you can gradually bump up the bedtime. Now this might require that you start eliminating naps or wake the child up a little bit earlier to accrue more of a, you know, a stronger EO for sleep. So once they're reliably falling asleep between 11:40 and midnight, but they're usually waking up at 9 a.m., perhaps you wake the child up at 8 a.m. And then that will hopefully have an effect on subsequent nights. Them, you know, seeking to go to sleep earlier, etc. And so the idea is to, again, decrease that latency between being in bed and falling asleep. And then you can slowly and systematically move up the bedtime to an earlier time that's acceptable to the family. But you want to do this over, you know, 10 or 20-minute intervals at a time. And then you stop the bedtime fading routine when they're falling asleep within 20 minutes of being in bed at an hour that's acceptable to caregivers. Again, this is definitely one of those scenarios where if the child is actually sleeping through the night, but the issue is what time they're going to sleep, you can let the parents sort of set the time that's acceptable for them. Some parents are perfectly fine with their children sleeping in or staying up late. And so I think the bigger question is are they sleeping through the night? And are they getting enough total sleep time? So, and also just one other note, you know, this process of systematically fading isn't much different than when we have to change the clocks back when there's daylight savings time or something like that. So Again, our target sleep time is 20 minutes within being placed in bed. So you can see I roughly, mapped out some scenarios. If the desired bedtime is 8:30, you want to find out when they're actually falling asleep, set the bedtime somewhat close to that, and then, get some consistency there, and then slowly back it up a little bit more. And you can do that by manipulating the wake time as well as eliminating any naps or things like that. Okay, the next protocol is called sleep restriction. And it follows a very similar principle of what we just talked about with bedtime fading. Here, this is also used for delayed sleep onset, but primarily night wakings is when I've seen it to be the most effective. The idea with sleep restriction is that you want to consolidate the sleep time. Multiple interruptions in our sleep schedule make for, less restful sleep. The opportunity to engage in that rapid eye movement level of sleep, which we need for memory consolidation and learning to take place, the night wakings are going to impact that. And so with the sleep restriction protocol, the idea is to aim for consolidation. There you go, I have it in red here. So step one is to temporarily reduce the children's sleep such that the child is in bed only 90% of the time that they usually sleep. So you're actually going through a slight deprivation stage, right? So if they sleep for 10 hours a night, simple math, you're now going to only have them sleep for 9 hours a night. Now keep in mind, if they're engaging in night wakings, chances are they're probably, losing some time out of that 10 hours. But if we, wake them up an hour earlier, for example, we can capture that. We can have them sleep for that 90% of the typical time. And that will usually consolidate the sleep and eliminate the night wakings. The body is really funny in this way. As I've learned a lot about sleep, is that, the effects of sleep deprivation on, one particular night sometimes don't show up for 24 or 48 hours of the following, night cycles. So if we have a situation where a child is engaging in multiple night wakings in the middle of the night, and we actually sleep deprive them on purpose, we're able to consolidate that sleep time. That consolidation will happen after a night cycle or two. And there will not be the same number of night wakings. Once the child is consistently sleeping through the night, through that sleep restriction period or sleep restriction routine, the sleep schedule will slowly and systematically be faded back to a more appropriate sleep. So instead of waking the child up at 6 a.m. to make sure that you get that 90% time in bed, you might wake them up at 6:15, right, for a while until you're sure that those night wakings are not recurring. And then maybe 6:30, make sure that those night wakings aren't recurring, 6:45, 7 o'clock. It might not be that simple to fade it back in, but the idea is that consolidated sleep is superior in this case if there isn't, depending on the total sleep time. But what we want to see is consolidated sleep as long of a block as we can. Okay, another intervention is called scheduled awakenings. This addresses delayed sleep onset, night wakings, but in particular has been indicated for night terrors. So individuals with autism display night terrors also. And I'm not sure how many of you have had the pleasure of witnessing this in someone that you've cared for or someone that you've known, but I only experienced it once or twice when I was babysitting one particular child when I was a teenager. And I did not know at the time when I was watching him that that was something that he, a condition he had, or, something that he had been experiencing. But it's pretty scary at first if you don't know what's going on. But the individual just wakes up spontaneously and is screaming, crying, on occasion sort of thrashing around, and their eyes might be open, but they're not responsive to, your vocalizations or trying to soothe them. And the idea is to just sort of leave them be, make sure that they are safe. But it's difficult. They're difficult to manage. And so the the recommendations for addressing night terrors are to have scheduled awakenings. So the idea here is that you're going to collect data on those night wakings or those night terrors. Now, night terrors might not occur at the same time every night, and same with, and they might not even occur every night, right? They might be once a month, which would make data collection a little bit tricky, because you need to collect a sufficient number of data points to be able to determine a trend or typical time of onset. The same might go for night wakings, but we're assuming that these would be pretty significant issues, and so hopefully there would be enough data points. But the idea is to collect the data on their occurrence, pinpoint that time of onset. Let's say that we know that these night terrors occur at 3:30 a.m. every night, or when they occur, it's usually 3:30 a.m., I should say. So what you would do if you have really clear data to indicate that that's the case, is that you would then wake the child up at 3:15, 15 minutes before the time when they previously were demonstrating that spontaneous night waking. When they're awoken, you then respond as though the waking was spontaneous. Not quite sure how to act this one out, but I guess, perhaps you jostle the child a little bit gently and then, pretend like you were there. But the idea is not to necessarily ask them to do anything, just, have them wake up fully. Essentially, that process of waking up offsets or decreases the probability that that typical night waking or night terror would occur 15 minutes later. So it's just a funny thing of the brain, I guess, with these night terrors. I'm not quite sure of all of the underlying mechanisms, but apparently it's incredibly effective. And then you systematically fade that over time to longer intervals of uninterrupted sleep. So I think in our sleep clinic, I only encountered one family who had reported night terrors, and they were relatively infrequent. And so I don't think ended up using scheduled awakenings, but I've been interested in this intervention because of the social validity concerns, right, about it. And apparently, again, the review that I'm sort of working off of here to give you all a consistent resource to use, the studies that have evaluated this actually inquired about the social validity of scheduled awakenings, and apparently parents reported that it was not too high of a response effort to address, and in fact it was less response effort than addressing a night terror. So I guess we can imagine that, the comparison of those two, it's probably more pleasant to just gently wake your child up and then prevent a night terror than it is to just be woken up spontaneously by one and have to then deal with it. So at first I sort of balked at this intervention, but it's apparently potentially worth it in the event that a night terror is a behavior to deal with. Okay, so that kind of concludes the discussion of the various antecedent-based interventions I wanted to talk about. The next two are consequence-based interventions. I'm going to start with standard extinction, and then I'm going to shift into graduated extinction, which is a modification of standard extinction. And just to review, extinction is the withdrawal or removal of reinforcement following the occurrence of a behavior. So this should be implemented when we see instances of bedtime refusal or night wakings. Excuse me, I'm starting to lose my voice here. So standard extinction, again, considering the fact that bedtime refusal and night wakings are likely controlled in some part or maintained by some measure by adult attention. I would say escape also for the bedtime refusal. We're going to provide extinction, attention and escape extinction for those. And so essentially, if I want to give folks a touchstone for this, if any of you have ever read, heard about, engaged in sleep training of a young infant, there's the cry it out method, right? Where you train the infant that they've got to self-soothe, right? So you withdraw all attention and let the child cry it out so that they fall asleep. After consistently implementing this that extinction protocol, the baby will then be able to be placed in the sleep area and have the appropriate stimulus control to sort of self-soothe, right, and fall asleep. Well, when we're talking about these bedtime refusal behaviors or night wakings, you know, we can apply that same principle: withdraw attention, withdraw the opportunity to escape. And it's a systematic withdrawal. So step one is to place the child in bed and provide a very salient cue, right? Good night interaction. So a hug and a good night, or tuck in the covers, whatever it might be. I don't know, the song, if we want to go all the way back up to the positive bedtime routines intervention. But it needs to be a very clear signal: it's bedtime, it's happening now, okay? Just matter of fact. Then leave the bedroom, and then chances are, if the child has a history of engaging in bedtime refusal and or night waking, they're gonna probably follow you, follow the adult, try to leave the room, engage in all that sort of hijinks that happens. And what happens is that the adult, you know, it's going to depend on the space. It's going to depend on the safety of the child, right? Like if there's furniture and the child has a history of, you know, property destruction, we don't want them to be hurt. We want to create a circumstance where the adult can withdraw attention and opportunities to escape this demand of being, you know, remaining in your room, remaining in your bed safely. And so they, you know, exit the bedroom. Perhaps you have to close the door and hold it. Perhaps the door stays open and the adult just systematically, without providing additional attention, without providing, you know, soothing pats on the back and, you know, cuddles and all sorts of rocking, withdraw all that attention and just very matter-of-factly return the child to bed each time they get out of bed. After a while, what we know about extinction is that the response effort, engaging in all that junk behavior, isn't going to be worth it because they're not accessing the reinforcement that they're seeking. And so this is essentially the cry it out method, but for, you know, ambulatory, you know, older children. So that's how you implement it. I have a video, again, homemade, entirely homemade. So use your imagination about the bedroom space. But hopefully you can see that the idea with the extinction protocol is that, you know, initially there are going to be, you know, all of the traditional problem behaviors that the child has displayed. And they're probably going to be at a high magnitude. And it's going to get worse before it gets better because it's an extinction protocol. In these cases, I actually tell parents, look, if it's getting worse than you actually know, that you've pinpointed the reinforcement and you're withdrawing it. Now, that said, I will talk next about some issues, right, with using standard extinction. But here you can see kind of a good scenario of the initial response by the child is a full-on tantrum, and then over the course of a few nights, it does get better, and as the contingency is has been, fully in effect. Good night, sweetheart. Good night. Okay. Sleep well. All right. Good night, bud. Sleep well. So, yeah, good job. Go to sleep. All right, so now I'm going to begin talking about graduated extinction. So recall that the exact same behavioral operation is in effect here. Extinction, there's the withdrawal and removal of reinforcement. In this case, it would be for sleep problems, it could be the withdrawal or removal of attention, of access to certain tangible items, but also escape extinction from escaping the sleep area. So I want to just back up a little bit and talk about some of the practical concerns associated with standard extinction. So of course, whenever extinction is in effect, there's a high likelihood that an extinction burst will occur. It's a sudden and marked increase in the targeted behavior before a consistent decrease is observed. In other words, the behavior is going to get worse before it gets better. And that's no different when you're withdrawing reinforcement from some of these bedtime refusal behaviors or previously attention maintained night wakings, for example. So there are some specific difficulties when we engage in standard extinction during nighttime to address these sleep disturbances. So if a parent ends up closing the bedroom door, withdrawing that attention, and trying to contain the child in the sleep area, any number of things could be occurring. So we don't usually recommend that approach if the child is aggressive or engages in property destruction. It's just not safe. So also, one of the reasons that we don't often recommend that is that parents will start to respond to the intensity of the behavior. So perhaps they can tolerate closing the door and not providing attention if there's some gentle whining, for example. However, when they hear objects moving around, they want to make sure that their child's safe, so they want to check on their child. And that causes them to violate that extinction schedule and potentially create an intermittent schedule of reinforcement or a schedule that is dependent on the magnitude of the problem behavior occurring on the other side of the door. The alternative to closing the door and just engaging in that clear indication of the withdrawal reinforcement is to keep the door open, but return the child to bed each time that they leave the sleep area. This can be rather exhausting, especially if the child has a strong reinforcement history with gaining attention and resisting being in the sleep area. So standard extinction is tricky. Given this extinction burst, I often check with families. I play out the entire scenario. And some families who live in apartment buildings, for example, it doesn't make sense to use standard extinction because walls are thin and perhaps they've already had complaints about nighttime behavior in that apartment anyway. So standard extinction presents some difficulties. Now, in side-by-side comparisons of standard extinction and graduated extinction, standard extinction is certainly more efficient at addressing these problem behaviors and reducing them. However, graduated extinction is rated to be more favorable by parents, and therefore the probability of its efficacy is greater because of the fact that parents are going to implement a procedure that is easier to carry out. They'll implement it with greater consistency. So it's helpful to think about a modification to the standard extinction protocol, essentially using the same exact operation, roughly the same procedure, but do it in a way that is a little bit more acceptable to families, that will allow for the safety of the child, increased safety of the child, and to eliminate or reduce the probability that a family is going to violate that extinction schedule once it is in effect. So this modification is called graduated extinction. So it should be used when there's bedtime refusal or night wakings. Again, when we want to withdraw any of that reinforcement associated with those behaviors. The idea here is that a parent is going to use a timer and they will enter the room on a time-based schedule instead of a response-dependent schedule. So rather than waiting for the child to really kick their tantrum up a notch and make it so that parents are worried that something bad is happening on the other side of the door, instead parents will go in the room, check on the child, perhaps return the child to their bed if they've left the bed on a time-based schedule. So I have, two pictures here of timers that can be, used as apps on a phone, but you could use any kind of timer, right? So egg timer, the timer on the stove, anything will work as long as the parent only enters the bedroom contingent upon that timer going off instead of contingent upon, really problematic behavior occurring. So the procedure is to, again, place the child in bed and provide a very salient cue. Good night interaction, leave the bedroom. Should sound familiar. This is what happens in standard extinction. However, step 3 is that the parent sets a timer, and that interval, that timer period, right, of 2 or 3 minutes is probably best to be based on that inter-response time of the behavior. At times I have asked families what is your comfort level? Sometimes families would like to start with an even lower threshold. It doesn't actually matter which option families choose, as long as the family sticks to it. And so they need to enter the room based on the timer buzzing. So if they choose 30 seconds, then the parent will leave the room after putting the child to bed, set the timer for 30 seconds, ignore the child for that period of time until the buzzer goes off, and then they will return the child to bed or check on the child. And then over time, that 30-second interval is increased such that there are longer periods of time when the child is being left alone or attention is being withdrawn. If the child exits the bedroom, I see a typo here, this should be step 4. If the child exits the bedroom and follows the adult, then the adult gently and silently physically prompts the child to return to bed. So if they happen to sort of cross that threshold, then the child would be returned to bed. But for the most part, the only time that the parent should be interacting with the child is again, based off of that timer. And so essentially you're separating that schedule of reinforcement that was previously just dependent upon the child waking up or the child engaging in particularly problematic behavior, refusing bedtime. And then now it's being switched to the parent simply providing a time-based fixed schedule of reinforcement. So I wanted to talk a little bit about a very brief study that I conducted with a client in our home-based practice where we used actually 2 interventions, the modified bedtime routine and graduated extinction. Again, as I mentioned, I'm a really big fan of the modified bedtime routine or the positive bedtime routine because it assists in creating a lot of structure around bedtime, nighttime for families, and addresses a lot of the antecedent manipulations, provides those antecedent manipulations that we need. And then we also use graduated extinction in this case. So I haven't officially written this up, but I wanted to share some of the information from this little study that we did. Our goal was to evaluate the use of this modified bedtime routine and graduated extinction procedure for a 7-year-old girl with autism who displayed a lot of sleep onset and night waking behaviors. We ended up doing a reversal design, and I can talk about a little bit why we decided to engage in that withdrawal. It actually happened somewhat naturally. And then we re-implemented intervention. So again, a 7-year-old with autism, the parents reported delayed sleep onset. So she was not falling asleep until about 12:30 in the morning, greater than 4 times per week. So more than 4 times per week, night waking more than 3 times per night, at least 6 nights per week. So it's quite frequent on both fronts. And then there wasn't any routine medication, which is just helpful to note, with the exception of Zyrtec daily in the morning. So the primary data that were collected were sleep diary data, ABC data on target behaviors, night wakings, and aggression were occurring. I also did some descriptive assessment, data collection, mainly just to try to assess some of the function. I should note also, didn't include it here on the slides, is that I had asked the family to make sure that there was a comprehensive medical evaluation assessing potential reasons why these sleep problems would be present, and there was no significant medical history and no indication of any other underlying issue. So we were pretty sure that it was primarily something that we could address behaviorally. So in any event, the descriptive assessment data indicated night waking served the functions of attention and escape. So here we had 2 parents. The participant's mother was the primary implementer of the intervention, and her father served as an observer, recording the target behaviors. We recorded the frequency of night wakings per 9-hour period. The total sleep time for this child was between 8 and 9 hours a night, and so we calculated the frequency of those night wakings as well as the percentage of time spent in bed. and that's calculated here by the total minutes between bedtime and wake time, and the cumulative total minutes of night wakings to multiply by 100, you end up with the percentage time in bed. Okay, for the baseline condition, there was not a planned intervention. Parents reported implementing a variety of different consequences, really reactive consequences, which I have to say is fair, and it's something that we encounter quite a lot, especially when parents are tired. There was a lot of assuaging, attempting to just eliminate the whining and the crying and some of the aggression and bedtime refusal as best as possible while keeping her safe and while the parents tried to get some sleep themselves. So it was a haphazard approach to addressing these behaviors. And during baseline, we just collected data. No training was provided regarding the modified bedtime routine or graduated extinction. So once we started the intervention phase, we took a very close look at the routine throughout the day and infused or incorporated considerations regarding sleep hygiene. Again, I'm a big fan of taking a close look at routine activities like bath time to see what effect they have on the child, and in this case, it was making her pretty hyper, made her more awake. And so we moved bath time to the morning, eliminated screen time 1 hour prior to bed, incorporated exercise outdoors for 30 minutes, and ended that 1 hour before bedtime. The second component of the intervention was the graduated extinction protocol. So when the child got out of bed, the mother would state back to bed and provide physical guidance to return to the bed. This was something that the family had come up with. This is what they wanted to say to her and keep it very consistent. In the initial interval of the graduated extinction protocol was 3 minutes with the door closed, and it was increased by 1 minute following 6 consecutive in-bed intervals. So you can see here, down here this is a graph of the frequency of night wakings. Down here I have on the x-axis the number of sessions. So it took a while, more than a month to implement this intervention. But you can see here on the y-axis, frequency of night wakings per 9-hour period. And so you can see the baseline range was from 4 to 7, but primarily 6 night wakings per 9-hour period. So that was pretty frequent. And so that was, I think, a pretty stable trend here in baseline. Then once we introduced the combined modified bedtime routine and graduated extinction, you can see that there was a bit, I think I would safely say this is an extinction burst, pretty clean one, in session 20, where there were 10 per 9-hour period of night wakings. And then a precipitous decrease here shortly after that, that just continued to decline until we ended up with 4 consecutive sessions at 0. So something interesting happened, and this could very well be a confound for this period of time. I was ready to, just simply end the intervention, but the family had a change occur. The mother came down with a medical condition and needed to spend a few days in the hospital, and the father would split his time tending to the mother and also to the children, and an aunt ended up coming and spending time at night. And so I think it was safe to say that certainly the graduated extinction protocol went out the window. and that, however, I'm not sure, I didn't, and I should follow up with them to learn more about whether or not the modified bedtime routine still was in effect and to what degree. So I'm not sure that this is a totally pure baseline, but in any event, you can see that there was a big change that occurred in how nighttime was being addressed. I think was clearly stated with respect to what the aunt was doing, filling in for the parents. And you can see, however, she continued to collect data, and we were able to see the data increase. And then once the mom was able to return back to the home, they re-implemented the intervention. So it's not the cleanest reversal design, but it is something that's kind of, I just was so impressed by the difference here in the potential functional relation that occurred here, that I wanted to share it. Don't usually get data this clean in clinical practice. Certainly not in homes. So you can see here's the percentage of time in bed. And here were the baseline data. So you can see the range from 50% to about 83% here. Somewhat variable here. And then certainly a change once we implement the intervention. Some change here in this, pseudo return to baseline, and then it creeps back up close to 100% here for percentage of time in bed per 9 hours. So what was particularly interesting to me, in addition to some of the data that we were able to collect, was a bit about the social validity of this intervention. The parents reported that it was difficult to implement. However, despite that difficulty, they're likely to continue to implement it over time. What was most important for me to see was that sleep improved for both parents in the household. I could tell that they were very much struggling with this behavior, and it was great to see that they were able to get more sleep. So, I wish that I had, and maybe I'll talk about this on the next slide here a little bit more, but I wish I had more objective recording across this little mini study of what was actually taking place, whether or not this child was sort of learning to be quieter at night or less disruptive, and whether or not her sleep actually improved. But I was happy to see that the parents' sleep improved. Again, it's unclear to me, once a modified bedtime routine is implemented, it's unclear how much you can actually take that away, especially if it's sort of just becomes part of the daily routine. And so that return to baseline, I still, struggled with how to label that on the graph to demonstrate for this talk. But I just wanted to be transparent that I'm pretty clear that I think the graduated extinction went out the window, but I'm not quite so sure if the modified bedtime routine had fully been withdrawn. So definitely some limitations in this little study. There's lack of objective and reliable methodology to record the participants' sleep behavior in the home. So I would have loved to be able to provide an actograph to the family to see if we could really record this little girl's sleep behavior. There was a lack of inter-observer agreement and procedural integrity data, of course. However, what I found to be most interesting was the threshold for the changes in behavior that would be socially significant for families. So in clinical settings, perhaps our threshold should be a reduction in disruptive nighttime behavior. Especially in this case, we can't say that her sleep behavior necessarily improved. She might not have been disruptively waking anyone up, but still might have been awake just as long as she always had been. But in any event, she wasn't being disruptive, as far as we know, was not being unsafe, and the caregivers were able to get some sleep. And so sometimes I think that's a big step in the right direction, is when we can't objectively say that there were improvements in the child's behavior. Okay, with that, I'm going to show you another homemade video, the final homemade video of this little workshop on graduated extinction. You'll see me entering the room when the child is engaging in some disruptive behavior, and then exiting the room, setting a timer, and only entering the room on a time-based schedule. And hopefully you'll be able to see that the problem behavior decreases over multiple trials. Again, it's contrived and it's just a demonstration, but I thought it'd be helpful to see how the procedure is carried out. All right, good night, bud. Good night. Just gonna, I'll be back in a few minutes, okay?
Really? Or just...
Right. Good night.
Okay. Yeah.
All right, so I have two more items I wanted to talk about in the remainder of this workshop. The next intervention I'm just going to very briefly go over. It's more a product I wanted to bring to everyone's attention if it's not something you're familiar with. I just learned about it a couple of years ago. So some children are early wakers, and this can be a little bit problematic. We talked about all the antecedent interventions to potentially increase, the total duration of sleep, to consolidate it, to eliminate night wakings, to have bedtime be earlier in the evening, but staying in bed or not waking up so early is a little bit problematic at times. If you've taken all of the steps to control the environment, blackout curtains are a particular favorite to ensure that the light, the daylight doesn't wake up the child. There are other approaches you could take to teaching that stimulus control, like it's time to wake up. Now, obviously, if the child is capable of reading a clock, you could teach some contingencies around that. You could teach the child directly and then have the family work on implementing that. But there's a neat little product called, and I'm sure there are a variety of them, so I don't mean to just market one of them, but this is the Mirari OK to Wake alarm clock and nightlight. The idea is that it's a night light, and it turns green, I think, to indicate that that it's time to wake up. So I think there are multiple settings. It could be completely with no light, and it can light up green when it's time to wake. So the family sets an acceptable time for the child to be allowed to leave the room. And that's the SD for them to engage in leaving the room, waking up for the day. So it's just a thought I wanted to share in terms of staying in bed, or at least staying in a particular place. I've known some families that they're able to provide activities for the child to do when they wake up. If the individual is capable of following an independent leisure schedule, for example, perhaps the night before, the family could set up the leisure bins or independent workstation for the child to engage in, just to eat up some time so parents aren't waking up with the child immediately. But I thought I'd share this option. I'm sure there are many products like it or similar to it. Okay, the last study I want to talk about was just an evaluation of a package of all of the individual interventions that I discussed today. So, it doesn't necessarily, or it might make sense, I guess, if the sleep problem isn't so persistent, to just address, just use one of the interventions. But most of the time we want to use a combination of different interventions in parent training or caregiver training. And so in 2012, 2013, we conducted this study. It was a randomized controlled trial to evaluate a behavioral parent training study specifically to address sleep problems versus a comparison group, the administration of a psychoeducation program. So I'll talk about the different groups and the different interventions now, but the main objective was to create this manualized behavior parent training program that would incorporate all of these different interventions and have essentially the interventionist tailor a plan, like a customized plan to address sleep problems. And really what we wanted to evaluate was the feasibility of such an intervention, as well as the fidelity of implementation by the caregivers, in addition to our fidelity. When you're delivering a manualized intervention, you're likely to have high fidelity as trainers to parents, but the question is sort of really where the rubber meets the road is the fidelity of the implementation of the caregiver to the child. And then of course we wanted to measure the initial efficacy of such a program. So we recruited 40 parents whose children were diagnosed with autism between the ages of 2 and 6 years old, and they needed to have a significant sleep disturbance. There's a questionnaire that is called the MSPSQ, or the Modified Simons and Paraga Sleep Questionnaire, that we use to calculate a score. But we also had a very detailed verification form that indicated how many night wakings per night, how many nights per week, or delayed onset of sleep occurrences were happening. Are they an early waker? It asked questions such as that, and depending on the responses to those questions, if it met a particular threshold, we would include them in the study. So it was a randomized controlled trial. So we had 40 participants, and they were each randomly assigned to one group or the other. We ended up with a little bit of attrition here, and I can talk a little bit about that. But the parent training was focused on sleep interventions, behavioral interventions to address sleep problems. And then instead of having a wait list or control group, we actually provided families with education on autism. Now remember, these were parents of children who were between the ages of 2 and 6 years of age, and their child had autism. So we gave them a lot of information about autism and resources and advocacy, information that parents of children with autism often want to know at that stage in their child's life. And we did this in order to control for the time we were spending with this group of families and the attention we were giving this group of families. After families enrolled, if they were randomly assigned to the Parent Education Program, the PEP program, then they were allowed to go through what we called an optional out-of-protocol treatment. So we would actually give them this training after they were good citizens and participated in the PEP program for our data collection purposes. So really what I want to focus on here in this workshop are the core sessions, how we structured this manualized intervention. So the first session that we conducted with the families, there were 5 sessions total. We delivered these over 8 weeks. And so we did this to build in some flexibility. So a session would last anywhere between, an hour and a half and 2 hours. And then depending on the parents' responses as we talked to them between sessions, we would schedule sessions, relatively quickly because their customized plan was requiring that they learn a little bit more to advance in the next stage of the treatment. Or if they needed a little bit more time to implement the intervention, we kept it a little bit flexible. So it wasn't as though we met them, every Tuesday for 5 weeks in a row. Instead, we had an 8-week period to try to get everything done. And the therapist and the family communicated about where they were in the process, when to advance to the next bit of information and training. So the first session really focused on behavioral principles to address sleep and bedtime problems. So we introduced the idea of behavioral contingencies, ABC data collection, how there are operations such as reinforcement and extinction and antecedent-based interventions, for example. So we gave them a big lay of the land in session A and asked them to go practice collecting their ABC data based off of their what they brought back in the next session. We refined their data collection practices, and we moved on to session B, prevention techniques and bedtime routines. This is also known as antecedent-based interventions. So we went through a whole variety of the antecedent interventions that were covered today. Session C focused on extinction and reinforcement of behavior. So certainly standard and graduated extinction were taught, as well as reinforcement of behavior to increase that compliance at bedtime. And then as families were implementing this and continuing to collect data on the antecedent-based and consequence-based interventions that we had introduced, we started to manipulate bedtime a bit more. Hopefully by this time, between session C and D, we were starting to see a bit more consistency in the bedtime routine, a bit more consistency, reliability, accuracy in our discussions with families about the behaviors that were occurring. So we would be able to now talk about fated bedtime, adjusting the bedtime, as well as stimulus control procedures. What are those stimuli that are needed for the child to occasion sleep, and how do we want to potentially change some of those? And then finally, our last session focused on generalization and maintenance of behaviors. So considering what it would be like for the family to go on vacation and have the child sleep in a different environment, as well as maintenance of behavior change. So having that maintain over time. Optional materials included, we determined we needed some booster sessions at times. Those included compliance training for those kids who were particularly difficult to address, if non-compliance had not previously been addressed around bedtime. We needed a little boost in that regard that wasn't in our typical core sessions. Also, some children presented with a lot of anxiety. And so we created a session that addressed nighttime fears. So a monster check, some very specific approaches to addressing phobias should they be there, and it be possible for us to address some of those elements. So I really wanted to talk about this package and demonstrate kind of what it would look like if you were to put all of this together. So we built that manual. And then, as I had mentioned, the PEP program was really intended to just control for time and attention so that we could talk to families, spend that time with them, and also record the child's sleep behavior in that period of time to see if our hypothesis was correct, that some training around sleep would actually improve the sleep behavior, and that the PEP group, there wouldn't be a change in the sleep behavior. You can see that the core sessions consisted of, again, information we thought families with children with autism would like to know, an overview of the ASD diagnosis, a lot of information about understanding and using clinical assessments, developmental issues common in children with ASD, so issues throughout the lifespan for families to help to prepare for, advocacy and support services for children with autism, and then finally treatments and treatment planning for children with autism, mainly being good consumers of intervention and stronger advocates. Okay, so recall this was a pilot feasibility study. We wanted to see if people would show up, and we wanted to see if they would find the time that they spent with us to be satisfactory. So in the feasibility domain, 98% of families across groups attended all 5 sessions, which I think was a testament to their interest in solving the problem, and also we were as flexible as we could be at a clinic-based site in making sure that we could accommodate their schedules. So the parent satisfaction ratings, this was a questionnaire, but in the PT group that specifically addressed sleep problems, the mean was 90%, with a range from 71 to 100% for the 13 participants. I could get into the attrition, why that happened. I think one family, if I recall, moved away, and 2 ended up not being eligible. I could find more information on that if anyone is interested. And then with the PEP group, similar sort of story, but 88.2% was the mean, and the range was 63 to 100% there. So a bit of a larger range, a little lower mean percent parent satisfaction. So our integrity scores were pretty high. With the PEP, it looks like there was quite a range there. I'm not sure if that was, looks like it's probably an outlier. With the parent adherence, this is the degree to which parents carried out, parents participated in the treatment. So we used worksheets, we used scenarios to attempt to determine how much the concepts that we were teaching them and these behavioral principles were actually, the family was paying attention and absorbing and understanding. So it wasn't exactly procedural integrity, right? We didn't have data of what they did when they went home. and implemented intervention. Nevertheless, this was another composite sleep index score that we had collected. This was actually a questionnaire that we provided to them, and you see that actually higher scores of the composite sleep index indicate greater sleep problems, and lower scores indicate fewer sleep problems. You can see they were relatively equivalent, the two groups. The PEP is in blue, and PT is in red, and we had 3 time points: baseline, week 4, week 8. You can see that the PT group went from this roughly equivalent point as the PEP group, and then decreased over time. So the sleep problems decreased over time, whereas there was less of a decrease here in PEP. So there is a decrease with the PEP group, but it wasn't statistically significant. Whereas this decrease in the PT group that specifically addressed sleep problems was in fact a statistically significant difference. Okay, the actigraph data, as I had mentioned earlier, there were not any statistically significant differences. That said, there was a tremendous amount of variability in the use of the actigraphs, the consistent use of the actigraphs. Families seem to lose them on a frequent basis. They encountered water on a frequent basis, rendering them, completely broken, irreparable. And then also, at times they just malfunctioned. So I wonder actually if we were to do this study now with the Fitbits, the fancier, more durable devices that are probably a little bit easier for little kids to use, we'd be able to collect more consistent data in that regard. In any event, this small randomized controlled trial showed feasibility and initial efficacy. PT was more effective than the PEP group at reducing sleep problems per the parent report. And so again, I want to highlight that, the actigraphy data didn't show any statistically significant difference, but the parents reported a significant reduction in the sleep problems. And again, it could be that the children had responded to these behavioral interventions and were quieter. My hope would be that they were actually sleeping more, and that was why the parents were saying there were fewer sleep problems. But sort of, there's always that lurking concern until you have those objective data from actigraphy or some other tool. However, parents did a great job as agents of intervention, even though we had a clinic-based delivery model. So the families came to us, got their parent training, and then they went back out to their home and implemented. So it was feasible and demonstrated efficacy, at least per parent report. Obviously, replication is needed using a larger sample. And some limitations are that attending closely to sleep issues could change sleep behavior just on its own. Having parents collect data on sleep behavior might result in parents tuning in and making adaptations on their own. So perhaps this was just education about how to address sleep problems, and families ended up following their own protocol that would suit themselves. So it's hard to say exactly that our manual was, that there's a clear functional relation there. There were also a lot of missing actigraphy data, and the time frame might be too brief to realize some of the true effects of the interventions, especially when it comes to the consequence-based interventions. It might take a little while for the extinction to really take effect and see greater decreases in those night wakings, for example. Also, the nature of sleep behavior, it does take a few cycles, perhaps more nights, more weeks, for the routine to really be set in place. And so I do wish we had had a longer follow-up period. So this concludes this workshop. I mentioned I have a comprehensive references list. I plan on providing the conference organizers with this slide deck, as well as a list of additional resources regarding this area of research. Here's my email address. So the unfortunate part about this asynchronous pre-recorded format is that I don't get to do my favorite part of giving talks, which is the question and answer element. So hopefully you all have some questions. Hopefully you have some comments. Hopefully this all made some sense. And you can feel free to email me any of those questions. I'd be delighted to talk further. I really enjoy this area of research, and really want to thank the conference organizers and Penn State for all of the work to put this conference together, and appreciated being a part of it. Thank you very much.